Nursing EKG mastery, 9 life-saving rhythms. Every nurse must recognise a production of the Sinoe Medical Association with Daniel Hamoudi, MD, and Imeni Benayachi, MD. A cardiac monitor can warn you that a patient is deteriorating, but only when you recognise the rhythm, assess the patient, and act correctly. In this lesson, you will learn 9 essential EKG rhythms and the nursing priorities that can save a life. Remember, always treat the patient, not only the monitor. Before naming a rhythm, use a systematic 5-step approach. First, check the rate. Second, look for regularity in the R to R intervals. Third, identify P waves. Fourth, measure the PR interval. It should be between 0.12 and 0.20 seconds. Finally, assess the QRS duration, ideally narrow or less than 0.12 seconds. Before naming any rhythm, assess the patient's clinical status. Check responsiveness, airway, breathing, pulse, and blood pressure. Look for signs of poor perfusion like altered mental status or chest discomfort. Clinical reasoning is your most important tool. Rhythm number 1 is normal sinus rhythm. The rate is between 60 and 100 beats per minute. It is regular, and every QRS is preceded by a uniform P wave. The PR and QRS intervals are within normal limits. Nursing priority here is to continue routine assessment and monitor for changes. Rhythm 2 is sinus bradycardia, a regular rhythm with a rate below 60. While a sleeping athlete might be stable, we worry about symptomatic bradycardia. Nursing priorities include assessing perfusion, establishing IV access, and identifying reversible causes like medications or hypoxia. Be prepared for atropine or pacing. Remember, do not treat the number alone. Treat symptomatic poor perfusion. If the patient is unstable with hypertension or syncope, prepare for immediate intervention. Oxygen, EKG, and IV access come first. Atropine is the first-line medication, but you must be ready for transcutaneous pacing if it is ineffective. Rhythm 3 is ventricular fibrillation. This is electrical chaos. The heart has no effective output, and the patient will be pulseless. This is a shockable cardiac arrest rhythm. Your priorities are immediate confirmation, activating the code, starting high-quality CPR, and delivering an unsynchronized shock as soon as the defibrillator arrives. Rhythm 4 is ventricular tachycardia, fast and wide. If there is no pulse, treat it exactly like VFib, CPR, and immediate defibrillation. If there is a pulse, you must determine stability. Hypertension or altered mental status indicates instability, requiring synchronized cardioversion. Stable VT may be treated with antiarrhythmics. In VTAC, the most critical nursing action is the immediate pulse check. No pulse equals defibrillation. A pulse plus instability equals synchronized cardioversion. Always ensure the synchronizer is on for the pulse-present patient to avoid triggering a shock on the T wave. Rhythm 5 is atrial fibrillation, the most common irregular rhythm. The lack of organized P waves and the irregularly irregular pattern are key. The major risks are reduced cardiac output and embolic stroke from atrial thrombi. Nursing priorities include rate control, anticoagulation assessment, and monitoring for neurologic deficits. Rhythm 6 is atrial flutter, identified by its regular sawtooth flutter waves. Similar to AFib, we monitor for hemodynamic stability and thromboembolic risk. If the patient becomes unstable due to a rapid ventricular response, synchronized cardioversion is the priority. Rhythm 7 is supraventricular tachycardia, super fast and usually narrow. For a stable patient, start with vagal maneuvers and prepare rapid IV adenosine. For the unstable patient with hypertension or respiratory distress, proceed directly to synchronized cardioversion. Always have resuscitation equipment at the bedside. When giving adenosine, warn the patient they may feel a transient sense of impending doom or chest pressure. A short pause on the monitor is expected. Always give it as a rapid IV push in the port closest to the heart, followed immediately by a rapid saline flush. Rhythm 8 is Torsades de pointe, a polymorphic ventricular tachycardia that twists around the baseline. This is often associated with a prolonged QT interval and hypomagnesemia. Nursing priorities include stopping QT prolonging drugs, checking electrolytes, and preparing IV magnesium. If pulseless, follow the arrest algorithm. Rhythm 9 is asystole, the absence of ventricular activity. Before acting, confirm the patient's pulse and lead connections. Asystole is a non-shockable rhythm. The priorities are high-quality CPR, epinephrine, every 3 to 5 minutes, and a rapid search for reversible causes. Do not delay CPR to give medications. During any cardiac arrest, systematically work through the H's and T's: hypovolemia, hypoxia, acidosis, electrolyte imbalances and hypothermia. Also consider tension pneumothorax, tamponade, toxins and thrombosis, both pulmonary and coronary. Rapidly identifying and treating these causes is the key to survival. Let's review. From normal sinus to asystole, your recognition and intervention must be rapid. Remember, VF and pulseless VT are shockable. Asystole and PEA are not. For stable rhythms, use medications or maneuvers. For unstable rhythms with a pulse, synchronize the shock. For no pulse, defibrillate. Finally, let's test your knowledge. Scenario 1. Chaotic rhythm. Unresponsive. No pulse. That's VFib, CPR, and defib. Scenario 2. Wide tachycardia. No pulse. Pulseless VT. Defibrillate. Scenario 3. Narrow tachycardia with hypertension. Unstable SVT. Synchronized cardioversion. Scenario 4. Flatline. Confirmed leads. Asystole, CPR, and epi. Scenario 5. Rate 42 with confusion. Symptomatic bradycardia. Atropine. EKG recognition begins with the tracing, but safe nursing care begins with the patient. Check the pulse, determine stability, and act without delay. Thank you for joining us at the Sinoe Medical Association. Like, follow, and subscribe for more medical education. I'm Daniel Hamoudi, MD. Stay clinically sharp.